happy. The women are happy because everything they couldn't say or do to their husbands, at this point you can't blame them, right? There is something called Vaira, at least in Tamil, it's called Prasava Vairagyam, the madness of labor. So, that is written off afterwards. It doesn't go on their account of being abusive to their husbands. So have husbands in the labor room. It's very, very important. The patient is comfortable. She allows labor to progress naturally. And antenatal classes. Do you need to have a big deal to have antenatal classes? No. You can do it once a month. If you're the only doctor, do it once a month. Put a few slides, explain to them, talk to them, explain what labor is like. Have the husbands there. Have the mothers and mothers-in-law there. Have people who are saying that she must have a cesarean, have them there. They will understand that labor is, you don't have to convince people that that's how babies are born. They know it. And encourage and support patients. That's the most important thing. And for heaven's sake, I Googled horoscopes and I found N.T. Ramarao's, which I thought was very appropriate for this audience. I don't know who's jobless enough to sit and do a jadagam for N.T. Ramarao. But people say, I want it at this time or that. 32 years did not give in to that. A huge practice, remember that. I didn't lose patients. If they left, they left. It's not a big deal. Okay, but I am not going to do a cesarean because it's this particular time or that particular time. I always tell them, why do you want to put your child into a cage and give it this particular future? If you really believe that the horoscopes make a child's future, you're putting it in a cage and saying, this is what your life is going to be. So do not do timed deliveries. Absolutely not. And if all of us do that, our cesarean section rates will change. Rethink indications. Okay, I'm going to run through quickly. Post-dated, wait till 41 weeks. Okay, it's not written in stone. You know that only 3 to 4% of babies are born on the actual EDC. Okay, so if you say, oh, 30th October, it's 1st of November, oh my God, we have to do a cesarean. No, patients, poor things, they'll believe it. So wait till 41 weeks. Cord round on the neck on ultrasound. If your sonologist reports it, change them. Go to somebody else, okay? Because that's nonsense. We know that 1 out of 3 babies are born vaginally, breathing well, crying well with cord around the neck. The mother is too large, too old, too small, and now the definition of old is coming down. Okay? Oh, she's 27 years old. I had a woman who was told, you're 25, you had your first baby, quickly have your second baby by 27 because by 28 we have to do your hysterectomy. Her life was timed. Okay, they had put a timetable on her life. Mother has GDM. Please do not use that as an indication unless there is proven macrosomia, and macrosomia to prove it is difficult. Only after 4, you really have to work at that if it's 4 kilos or more. Mother is hypertensive only if there's growth restriction. Otherwise, just because she's hypertensive, you can still induce her. Oligohydramnios, please use a correct definition. It's gone from 8.3 to 7.4. Oh, see, the fluid is dropping. They'll believe it. What do they know? But you know that next day, if you ask her to drink some more water, it can be 10, right? So please don't use the wrong definitions, 5 and below, and even that, if you have a good single deep pocket of more than 2 centimeters by 1 centimeter width, you can go ahead and induce them. PROM, you can induce them. Multiple gestation, if the first baby is cephalic, you can certainly go ahead and deliver her vaginally. Presence of fibroids is not an indication for a cesarean. Okay, you can get into more trouble doing a cesarean. If everything else is going well, you can certainly allow her to deliver vaginally. Then rethink your practice. Okay, what we did, because my issue was I'm spending 8 hours in the labor room. I can do a cesarean section in 15 minutes. Okay? Why should I be charging more for the cesarean section rate? Secondly, I didn't want patients to say, oh, she did a cesarean because her charges are more. All right? And so more than a decade ago, we made our delivery rates exactly the same, whether it's vaginal or cesarean. So nobody is tempted to do a cesarean, or nobody is tempted to point a finger at us and say, you've done a cesarean. No, the hospital charges will change, but the doctor's fees will not change. Okay, and if I tell you youngsters how much we used to charge, you'll laugh. We used to charge very little because I'm hearing things like 25,000, 28,000, 30,000 for the doctor in Chennai, and I wish I had not retired. Right. Training in external cephalic version, vacuum birth, forceps birth. All my girls, when they joined me as a junior registrar, I sat at the bottom of the table, both of us on stools. She did it, husband sitting there, no problem. They know that I'm there, and you train them exactly how to put forceps, how to use a vacuum. So you train them, you help them do an external cephalic version. All my doctors who trained with me could do that. So it's important that you pass on your skills. And bringing in midwives and junior doctors for low-risk deliveries. I know Fernandez in this hospital, in this city, has brought in midwives. People are very, very happy with it. And low-risk pregnancies, you can allow your junior doctors as long as you have trained them through a certain, you can't just throw it in, she's just finished her MD, she comes 3 days later and you say, go ahead and do the delivery. That's foolish. You have to put in that effort to train her over maybe 2 years. Right. Audit your cesarean section rate. And this does not come from one day, the government is going to turn around and put this as a mandate, and then when you do a 20% cesarean section rate, they're going to jail you. Okay? So before it comes in as a mandate, start auditing your cesarean section rates. We used to love doing this because we love to know what our cesarean section rates. So most importantly, it must be perceived as necessary. Whether you do 10 deliveries a month or you do 100 deliveries a month, you must check this. Okay? And we were doing 80 to 100 deliveries a month at one point, and then we brought it down to about 50 to 60 because we realized that the kind of care we can do. So if it depends on the number of deliveries you're doing, but whatever it is, you have to perceive it as necessary. It must be part of your clinical processes and protocols, and your statistics must be public. Any patient who came in for her antenatal checkup, and the first thing they will ask is, will I have a normal delivery? I'll tell them, your chances of having a normal delivery are 80%. And if it's the first baby, your baby's head is down at term, and you've crossed 37 weeks, and it's a singleton baby, your chances of having a cesarean in this hospital is 9 to 11% only. Okay? So if you can make this public, they're much, much more confident about coming to you, right? Quickly going through the Robson criteria, and this has been around since 2001, and we adapted it right away, particularly the first group. We didn't use it for all the groups. The first group, we definitely adopted it in our practice immediately. And it's based on obstetric characteristics, very simple. It's not difficult to calculate. Parity, gestational age, onset of labor, when did it start? Was it spontaneous? Was it induced? What is the fetal presentation? Whether she's had a previous cesarean section, and the number of fetuses. Very simple. And the WHO in 2015 has said that this is the best audit tool for cesarean sections, and it should be taken up by every institution which is delivering babies. The Robson's criteria, as I told you, is just very simple. These are the things that we look at. I've already told you about it. It's totally inclusive. Any kind of permutation and combination, and this is available anywhere. Just say, Google it and say Robson's criteria, okay? It's there. It's totally inclusive. Any kind of permutation and combination for pregnancy is there. It's mutually exclusive. None of them overlap. None of the criteria overlap. And the first one is one I'm going to talk about because the rest you can read up. Nullipara singleton cephalic, more than 37 weeks, is 37 weeks or more in spontaneous labor. Then all these other ones, it goes on. And 6, they say that across the world right now, their cesarean section rates for single breech is 95%, okay? So that TBT has made a lot of difference. I did cesareans for all my primary gravid breaches. So this is the Robson criteria. And where can we make the difference? To keep our cesarean section rates down, where can we make the difference? In number 1, which is a nulliparous who comes in spontaneous labor. She's singleton pregnancy, cephalic presentation, and she has crossed 30. She is no longer preterm. Okay? In this, our cesarean section rate was 9 to 11%. Occasionally, it has gone up to 15%, and we would look at our protocols, what went wrong, why was that 15%. Otherwise, it would be 9 to 11%. These included my induced patients also. Please remember that it was not just 1, but it's 1 and 2A, the induced nulliparas also. The term multiparas in spontaneous labor or induced, very low. In fact, the spontaneous ones were about 3 to 4% cesarean section rate. They came in, they delivered, okay? Because we made sure we gave them all the support. If necessary, we augmented them. We went through that whole process. And in a previous cesarean section, if you look at the indications, you can choose 50% which are, and don't press the bell, I have to, okay? Don't press the bell. I know exactly what timing distracts me. So in a previous cesarean section, you choose 50%, only 50% of them you can allow for trial of labor or VBAC, and of those, 50% will deliver vaginally. And you have to have all the things ready. You must have the ability to do a cesarean within 30 minutes. You should have, and we informed the anesthetist every time we had something where we thought something was going to go wrong, okay? So the anesthetist always knew. So we had 3 anesthetists on call, and we know the hell we go through when the anesthetist is not able to make it. It takes a little longer. We've all gone through that nonsense. It's terrible. It's a terrible situation to be. And so these are the situations, these are the 5 groups where you can actually make a difference in bringing your cesarean section rate down. Okay, so coming to the most important thing. How do we bring our cesarean section rates down? By having the will to bring our cesarean section rate down. It's very simple to do a cesarean, okay? You're in and out, half an hour, 45 minutes, 1 hour at the most, okay? Very easy. But you're leaving a woman with a scar. You're doing something which goes against nature, and you can still have a very low perinatal mortality with a low cesarean section of 20 to 25%. And I think we all need to make our cesarean section rates public. And I know of only 2 hospitals in the country, one in the north and one in this city, Fernandez Hospital, which every month puts up its statistics. And I know how painful it is to bring our problems out into the public. Okay, because we know people point their fingers without pointing a finger at themselves. They say, oh, their cesarean section this month was so much, okay? But the fact is when you do that, you give yourself a mirror in which you're looking, and you constantly are trying to improve yourself, all right? So, how do you reduce cesarean section rates? From within, okay? It doesn't have to be a small unit, big unit, huge support. You have to work around it. It is only you who can do it. Thank you very much.